Here is a simple ECG for discussion. Standardization is seen at this end. Usually it is seen at the other end, but here you have seen the standardization here. Nice square pulse, rectangular pulse I would say, is seen here. And PR interval is okay. The axis is not deviated, it's usually in the around 90 degrees. Lead one is equiphasic and AVF is positive. So it's around 90 degrees, plus 90 degrees. And in V1, you can see a small r, s and an r prime wave. It is better seen in V2, that is RSR prime pattern with a normal QRS width suggestive of incomplete right bundle branch block. Here the labeling is also different, that is because of a different type of machine. Instead of V1, V2, V3, it is written as C1, C2, C3. That's different type of machine. And there is T inversion in anterior leads up to V5. This could be part of incomplete IRBBB, but it's a little unusual in that it seldom goes up to V5 in incomplete IRBBB. So there could be something else. Coming to the lateral leads, you see deep S waves and tall R waves. So much of depth of S wave in lateral leads is unusual. That indicates there is a right ventricular problem because V6, V5, if the S wave is very prominent, that means right ventricle is thickened or hypertrophied. And R wave in V6 is also quite tall, indicating left ventricular hypertrophy. In fact, the R wave of the V6 is overlapping with S wave of V5 so that you are not able to see the full extent clearly. When there is such overlap of tracings from two leads, you have to take the ECG in half standardization so that the overlap can be avoided. But then during calculations, you have to multiply the visible amplitude into 2 also. Then only you can get the correct assessment. Anyway, that has not been done here. But you can somewhat see that the R wave is from here to here with the overlap. And S wave is from here to here. This is the overlap region of the two tracings of V5 and V6. Similarly, there is overlap between V4 and V5 also. So this person has features of incomplete right bundle branch block, extensive anterior T inversion, evidence for right ventricular hypertrophy as deep S wave in V6, as well as left ventricular hypertrophy with tall R waves in V6. And the QRS axis is almost plus 90. PR interval is not significantly prolonged, it is within normal limit itself. So biventricular hypertrophy, incomplete right bundle branch block pattern. That's what is seen here. And careful observation will show there is some fragmentation of QRS here. This is fragmented QRS is seen here. This is fragmented QRS. So actually this person had double outlet right ventricle with ventricular septal defect and pulmonary hypertension. That was the reason for biventricular hypertrophy pattern in ECG in this case. Double outlet right ventricle with ventricular septal defect. That will appear almost like a VST with large shunt, and there was pulmonary hypertension.